Okay, so this is only a very quick snippet of survival analysis. If you want to really see how survival analysis is done in a very sophisticated way, there is a Harvard School of Public Health Biostatistics department. There are a whole course on survival analysis, but we will just give you the very basic idea. So traditionally, survival analysis was done, say, in a clinical trial setting where a patient could be going through one treatment versus another treatment. Say you are developing a new drug, you treat the patient with a new drug, compare with patients who were either not treated or treated with traditional method. Say comparing a targeted therapy with a chemotherapy, or comparing with with placebo, or placebo is just no real treatment. And you want to see, do patients receiving a particular treatment really live longer? Or you can ask, are smokers more likely to have cancer occurrence? There should be an O, occurrence. And so there are events in this case, right? So events could be, in the smoker case will be detection of cancer. But if you have like a clinical trial for treatment, then the event could be cancer deaths, right? So one important thing for survival analysis is called the censored data, which means that the value of a measurement or observation is only partially known. For example, in this kind of a treatment clinical trials, you could see that some patients left the study. They maybe going through the treatment, maybe because of toxicity, they do not want to continue the treatment anymore. Or for some reason, they just left, they moved to a different city, they now are seeing doctors in a different hospital, or something like that. You just don't have all the information. The other one is, say, if you have a clinical trial, it only runs for 5 years or maybe 3 years. And at that time, the patient is still alive and you don't know what happened after that. So these are kind of censored. And so you can see in case like this, in a very simple example, it's like this. We are doing days, but in reality, we're probably doing this in months, in a clinical trial. You can imagine this as either day or months or even years. So supposedly, in day 1, we have 4 patients under the study, right? And in day 2, well, you can imagine as like month 2 as well. 1 patient died. We still have 4 patients under the study. And if you look at the death is 25%, the survival is 75%, and this is the survival probability is 75%. And then in day 3 or month 3, you could have 1 patient who left the study. Its C is censored. You do not know what happened to this patient. They just dropped out from the study. So at this time, there were only 3. At the beginning of the time 3, you only have 3 patients under the study. So like the probability of survival at this time is, from here, nobody has died yet. It's 1. But since this patient actually just left the study, your overall, like the survival probability you inherit from the previous time point is 75 because 1 patient already died. And then in the 4th time point, 1 patient died. We know there were 3 patients before, but since 1 died, 1 died here, 1 left the study. Now we only have 2 people that are still under observation, and 1 died now. So the survival probability at this time point is 50-50, right? 1 patient still alive, the other patient died. And so we use the previous survival probability, 0.75, times the probability of 0.5 here to calculate the overall survival probability at this point. Okay, so that's 0.38. And then at the 5th time point, 1 patient left the study. And then so we don't have information. We just say, maybe still survive. And then the survival probability will be the same as before. Right, so you can see censor is a big issue in here. And so if you calculate the survival without censoring, so let's look at this situation. So we have different time points. You can imagine this as months, right? This is the total number of patients. These are the actual death events. If you do not consider the censor event. So for example, we know there are a total of 21 patients. Every time you only calculate how many patients died, then the survival probability would be, for example, at this point, we have 2 patients die, and so the survival probability would be 90%. And then at this time point, 2 people died, and so we know that there are like 17 patients out of 21 died, and at this time, you have so another death. So 16 patients out of 21 are still alive. So this is, like if you don't consider censoring, this is your kind of probability of survival with time. However, if you really look at this number, you will notice that there are patients, if we didn't consider this column, this is the censored part, where there are, let's see, hold on, let me see, which one is the censored? Oh, sorry. Let's see. This is the surviving past this. I have to see which one is the censoring, which one is the, so the M is the deaths, and 1 is the people who left the study, right? So those, we don't have that information anymore. And so after considering this, we will say that at this time, the survival probability is still 1 because all the patients are alive. And at time 6, let's see, 3 patients died and 1 patient left the study. And so at this point, we still do 18 out of 21. This is the survival probability. And those patients who are died should not go into the next denominator anymore because they already kind of died, is also kind of left the study. But then there's also 1 patient who is censored, who for some reason we can't follow them anymore. So we only have 17 patients that we are able to follow. And so the denominator here is no longer 21. You just inherit the previous survival probability times we know 1 patient died, and so 16 patients we know are still alive, divided by the total 17 subjects that are still under your investigation. And so that's the survival probability. And in the next one, because 1 patient died, 1 patient censored, you have only 15 patients under consideration. 1 patient died, 2 patients left the study for some reason. And so you inherit the previous survival probability times 14 still survive divided by the denominator. So every time you take out the patients who are either dead or who left the study, and you calculate the people who you know for sure were dead, like you subtract those out. So this is the probability of alive based on the 15 patients, but then you inherit the survival probability from the previous time point. And this is how you can calculate the survival probability with survival with censoring considered. Okay, so you can see this is very, very different from your previous analysis now. Okay, that's why. Considering censoring give you quite a different story from without considering censoring. And so in order to really see whether the survival is different between, for example, in our case, you could look at survival difference between 2 groups. Say we do cancer subtyping. How do we know the subtyping is different, is really biologically meaningful? Is you look at the survival curve. This is called the Kaplan-Meier curve. You could do 2 groups. In this case, say you do a subtype, say lung cancer. This could be 3 different groups. or 2 or 4. But you look at the survival. Yeah, so this is the survival probability you see. And you are just asking, so here is the probability of survival at each month on this study. This is up to 8 years, right? And you can, the goal is to see whether these two curves are significantly different from each other. And so in this case, yeah, you would probably say that this subgroup and the other subgroup are very different. You could also look at, say, same group of patients, one treated with drug A, the other treated with a new drug that's under development. And you ask, are the patients treated with the new drug giving patients better survival overall? And so in this survival curve, you're just asking how good are the separation between the two groups. And so on this, you can see these little ticks in here, right? So these are the censored data, which means some patients left the study. So here, whenever you see a drop, that means there's a death event for that group, right? Because every time you have patient die, the percentage of patients still alive will decrease. But there are also cases when there's this little tick that means some patient just somehow drop out of the study, okay? Yeah, so in order to really see whether there is a statistically significant difference between the two groups, we also do some statistics in this case. So the very simple case is called the log rank test. Yeah, so at each time we are asking, this is the different time, and this is we're looking at the two different groups. Supposedly we started from 21 patients in group 1 and 21 patients in group 2, and this one is asking the death event. How many patients died in this case? Okay, so can you guess what our null hypothesis is in this case? Exactly. So you are asking, if the two groups, whether you are separating two groups by the subtyping or separating the two groups by their treatment differences, you're asking the null hypothesis to say the two groups are the same. They have the similar probability of death over time. But then you now look at the two groups and you ask, really, do they have the same death event? Okay. Yeah. So you can see this one when you have the two deaths in the very first time point. You are really expecting the deaths to be evenly appearing in both groups. But then what you observed is that all the deaths appeared in this second group, but not in the first group, right? And then in the second time, again, we have only 21 patients left, 21 patients left in group 1, and 19 patients left in group 2, and yeah, 2 death events in group 2. And again, you can ask, if we have a total number of 40 patients now, if 2 death events happened, the expected one is that they should happen equally in both groups, but the real observation is that they actually died more in the second group, right? And then so on in the third group, and so on. So in each of the case, you calculate the expected death and the actual observed death, and you want to ask what is the difference. And at every time, you can make some estimate. And the idea is like, if supposedly the death risk across each group is fairly constant over time, with all the data you observe, can you ask, what is the overall death risk in the two groups? And you can calculate, the proportion in risk sex is depending on your total number of patients in group 1 versus group 2. And this is the number of death events in group 1 versus group 2. You can calculate your observed subtracted by the expected, and then see how variations, how much variation you have in the two groups over time. Yes, Jet.
Why is it called the log rank test?
That's a really actually good question. I don't know. It's a good question. I'll go back and check. Yeah, sorry about this. So you can see whether the two group of patients are different. And so just make sure that when you have censored data in this case, every time you calculate this, you need to consider the people who actually were censored to calculate the correct death probabilities. Okay, so that's all. This is if we only separate the groups by, say, a categorical situation, say, based on expression, we already know how to separate patients, or based on the treatment, we already know how to separate the groups. You can do this log rank test. So you are only considering one factor at a time, and you can clearly divide your groups into group 1 or group 2, or even group 3 to look at the difference. Sometimes you can look at multiple variables. So for example, we could ask whether body mass index make a difference, whether patient age make a difference, whether you can have multiple variables, right? You can ask whether there are some other heart rate or whatever play a role there as well. And so you could have multiple variables that play a role, and each variable, you don't know how much they play a role here. So you can use kind of you can estimate kind of the hazard, or hazard is basically, you estimate the overall kind of a death hazard in some sense, so that if you have a hazard of above 1, that means it's more likely to die. But if you have a hazard less than 1, it means that the patient is less likely to die. And so you're asking for each factor, how does that influence your hazard? But then there might be multiple variables involved, and so you can estimate them together in a regression setting to ask, if you want to do this, first of all, you probably need more patients, right? You need in this case, TCGA, you can have hundreds of patients. So let's say like you have a phase 3 clinical trial of a few hundred patients, you can separate them out and you ask what factors really play a role, and you can put in these different variables. So first of all, the Cox regression allow you to have multiple variables that you can estimate their effect. In addition, each of the variable can be either discrete, which means male or female, right? That's a categorical, or it can have a continuous variable. Say, each patient has an age. You ask whether the age play a role. So you put the age as the X. Each patient will have an age, and you can ask whether that influences the survival as well. Can you use age in a log rank test as well? Log rank only separate the two groups with categorical result. But if you are trying to see the age, can you also use log rank? Yeah. So potentially you can just say, I take the median age and separate the above average and below average, right? But you can see that kind of is arbitrary. You can cut at different lines as well. And that's why kind of Cox regression, first, it can accommodate multiple variables, and second, it can accommodate continuous variables, right? And so in Cox regression, usually you see this Cox proportional hazard regression. So the proportional hazard is means that you assume the hazard for individual is a fixed proportion for any other individual. So in this group, basically you're assuming that this group of patients, over time, their death risk is quite similar. Whether they die or not is just because of all the factors kind of added together, but they don't, this curve kind of don't really change. Whereas if you have a case like this, initially the first group of patients die, like this group of patients die faster, but for some reason later on this group of patients dies slower. It means over time the hazard or the death risk actually changed. Then you cannot use the Cox regression, right? So most of the time you have I guess better power when you are trying to just estimate one constant rate of death. Okay. So as we mentioned, Cox regression can accommodate multiple variables. Therefore, you can imagine if you have, say, 3 genes you think, oh, maybe these 3 genes are related to survival. Can we use 3 genes to say whether together they influence risk or the hazard? You can imagine the X1 will be gene 1, XB will be gene 2, and X3 will be gene 3, and you estimate a coefficient for them to see does that influence the overall patient death, right? And with Cox regression, because it's a regression, it will try to give each gene a different weight in order to see whether you see a good survival difference. And sometimes you could see this, right? So you can separate the 2 groups by a gene expression signature. However, if you have very big gene signatures, you have to be careful because Cox regression try to give a weight to different genes. And if you have too many genes in your signature, like 300 genes, it will kind of tweak the parameters on each gene to really give you that survival difference. And this gene set really may have nothing to do with your cancer type. It just somehow captured something, could be like overtraining or something. And so anytime if somebody tell you that they have a gene expression signature, and if they have to use Cox regression to give a weight on each gene, you have to be careful. In order to see whether that signature is real, you could potentially randomly select the same number of genes from this expression data set to run the Cox regression and see what is your a p-value of separation to really see whether the signature you have has real statistical power or giving you better p-value of the patient survival. Yes?
What's a good number for the GPU?
I would say if you have to use Cox regression to give weight and you have over 100 genes, you probably should do some random sampling to make sure that you are not getting some random garbage. If you only have 12 genes or 50 genes, it's probably okay. It's not less likely to be overtrained. Okay? So that's on the very quick survival analysis. By the way, on the course website, we gave you some other lectures to explain more detail about